Okay, so we're continuing. This is part 2 of Evening with an Imp, the YouTube video part 2. So the question is, if you go back to Barbara Starfield's quote, that it's what we do with the disease that's expensive, let's look at that real quickly. Let's do a comparison between high and low cost regions. And what we find that is that if you have high cost regions, overall quality is about 37% worse, access is 10% worse, continuity is 37% worse, efficiency 63% worse. In terms of educating the patients and their knowledge of their diseases, it's about 28% worse, and hospital use is about 17% worse. Basically, where you have high cost regions in the United States, you actually have the worst quality incomes. It's an inverse relationship, which is totally counterintuitive. But what about the patients? I mean, do they feel like they're actually getting good care when they do get care? I mean, it's not just about trying to understand they're achieving goals, but do the patients feel like they're getting good care? And the answer is, well, based on a Wasson and Morse study in 2006, that only 30% of patients say they get exactly the care they want and need when and how they want and need it, and 35% say they receive perfect care. What that means is 65% of patients believe that their care could be better. Again, not a good statistic. So the overview of the United States healthcare system: quality remains poor over the past decade, even though the absolute numbers have gotten better. So for instance, life expectancy has gotten better. It's just other countries' life expectancy has gotten better much faster. And again, U.S. healthcare has not been improving as fast as other nations. Costs have been increasing faster than most other nations, and we're on a totally unsustainable path. High cost does not equal high quality, and 65 to 70% of patients are not completely satisfied with the care they receive. So with that overview, I would say that definitely the U.S. medical system is toxic to patients. Well, what about physicians? Well, let's look at physician satisfaction real quick. What you find is this wonderful article in JAMA of 2003, where they said that autonomy is the most important predictor of physician satisfaction. And what they meant by autonomy is being able to take care of your patients without outside interference. That goes along with all the other things: the ability to manage the day-to-day interactions of time and ability to provide high-quality care. Those are all predictors of physician satisfaction. Interestingly, income was much lower on the list. So generally speaking, physicians are pretty idealistic still in what they're looking to get out of the relationship. Unfortunately, 30 to 40% of U.S. physicians experience burnout at some point, and that's seen in many other studies. In Archives of Internal Medicine, 2002, 43% of primary care physicians were very satisfied with their choice of medicine as a career. That, of course, means that 57% are not. And a follow-up study the next year in JAMA showed that only 38.5% of primary care physicians were satisfied with their choice of medicine as a career. Again, though, this is back in 2002, 2003. What about newer stuff? Well, in a family practice management article in 2008, even 59% of family physicians would choose a different career if they could go back in time, and 22% wouldn't go into medicine. 37% would be a surgeon or a diagnostic specialist. That's pretty sad. I mean, if 6 out of 10 family physicians would not become family physicians again if they had a choice. That really shows how bad the system is currently abusing them. Actually, even back in 2010, just a year ago, the Virginia Academy of Family Physicians did a member survey, and 295 people responded. Interesting questions. Do you plan to retire in the next 5 years? 20% of the physicians said yes. But again, this other question, which I think goes to burnout: if you could retire in the next 5 years, would you? And almost 60% said that they would. Again, we're hovering around that 60% dissatisfaction number, really almost everywhere every study we look at. So I would say there's no question the U.S. medical system is indeed toxic to physicians. So let's go on to the second myth real quick, and that is that disease-focused care is the backbone of high-quality medicine. And actually, the reality is effective primary care is based on the doctor-patient relationship And that is the essential component of any healthcare system. There are numerous studies showing that that primary care is an essential part of the healthcare system. I'm not going to go into them very much, but basically, probably the Britakis is the latest one out of all those, showing patient-centered care is associated with decreased healthcare utilization. I think there's an abundance of data showing that really good primary care is essential. When you look way back, 2001, Institutes of Medicine, crossing the quality chasm thing, they actually pulled out 10 different things that they thought would be essential for healthcare redesign. Care based on continuous healing relationships, customization based on patients' needs and values, patients as a source of control, shared knowledge and free flow of information, evidence-based decision-making, safety as a system property, a need for transparency, anticipation of needs, continuous decrease in waste, and cooperation amongst clinicians. Of course, all of those make total intrinsic sense, but unfortunately, it's also very esoteric. There's no, let's say, roadmap as to how to necessarily get to these different things, and so it leaves the door open for interpretation for sure as to what might be the best path forward. So let's look at components of effective primary care. This again goes back to the Starfield call on June 1st. She said that she basically describes 4 basic things, and that makes it, I think that kind of summarizes it, takes into consideration all the 10 things that the Institutes of Medicine put forward. The first is first contact care, and then person-focused care over time, comprehensive care, and coordination of care. What she said, though, that I thought was interesting on the call was that you have a structure and a behavior for each of those components. So the structure of first contact care is, are you accessible? And then the behavior is, do the patients use it? So even if you are accessible, say 24/7, do the patients still choose the emergency room or the urgent care over you? Person-focused care over time. The site is responsible for the population, but you need to have really good follow-up and longitudinal care over the course of time. So it's not just a matter of being person-focused for that one visit. It's a matter of doing it over a long period of time. Comprehensiveness, of course, it involves range of services, but are the services provided when needed? I think that's an excellent question that we have to look at in each one of our own practices. And then coordination, there needs to be the mechanism to transmit the information, of course, but is the information recognized and actually read by the receiving physician? Again, a structure and behavior for each of the components of effective primary care. And that's going to end the second part of a second YouTube video.